Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go take advantage of that free Top 200 study guide. Great refresher if you're out in practice. Also, if you're taking board exams, preparing for that, definitely a no-brainer to have. It's a 31-page PDF. I highlight some of the most important things you're going to see in clinical practice, as well as some of those things that are going to show up on exams as well. So you can get that, reallifepharmacology.com. Simply an email is all that will cost you, so go take advantage of that. All right, the drug of the day today is ciprofloxacin. Brand name of this medication is Cipro. Ciprofloxacin is a fluoroquinolone antibiotic. Often we just say quinolone antibiotics just for shorter, less word vomit there, I guess, if you will. It's an antibiotic used for bacterial infections. And I would say primarily I see it used most for urologic type infections, urinary tract infections. Prostatitis is another example. But it can be used for other things as well, intra-abdominal infections, certain types of infectious diarrhea, for example, and on the rare occasion, maybe for a respiratory tract infection as well. And I'll talk about kind of that coverage a little bit of what bacteria it covers and which ones it doesn't, and in particular in relation to respiratory infections, why you don't see it too much for community-acquired pneumonia, for example. All right, so mechanism of action, let's touch on that briefly. This medication inhibits bacterial DNA gyrase and topoisomerase. So these are critical enzymes that are important for bacterial DNA replication and transcription. And obviously, if those processes are interrupted or blocked, that can ultimately lead to cell death. Getting into the bacterial coverage a little bit deeper here. So I alluded to ciprofloxacin not being the greatest for community-acquired pneumonia. Let's compare that to, say, levofloxacin, which is frequently or can be used more likely for that situation. The reason ciprofloxacin isn't is it has some weaker activity against Streptococcus pneumoniae, which is one of the most common bugs associated with causing pneumonia. So obviously, if you're choosing empiric therapy on covering for community-acquired pneumonia, you want to make sure that bacteria is going to be killed by the antibiotic you're using. All right, talking about further coverage purposes for ciprofloxacin. So a lot of the gram-negatives Cipro will cover, which are common in urinary tract infections, for example. So your E. coli, your Klebsiella, Proteus, for example. These are bacteria that Cipro is definitely going to have coverage for. One unique one that obviously ciprofloxacin has an oral dosage formulation is Pseudomonas aeruginosa. This can be a pretty resistant bug, so ciprofloxacin potentially having coverage against that may be utilized at times as well. Some of the kind of upper respiratory type infections, Haemophilus influenzae, MCAT or Moraxella catarrhalis, these can be covered with ciprofloxacin, but there is some evidence that we do potentially have some resistance with some of those bugs as well. So that's why you don't see it used too much for sinusitis, ear infections, and things of that nature. And then we've got some coverage against Salmonella, Shigella. These are often causes of infectious diarrhea, for example. So we've got some coverage there potentially as well. Dosage forms, let's touch on that a little bit. So we've got oral and we've got IV. Oral dosing range is typically in the 250 to 750 milligrams twice a day. Every 12 hours is probably the most common range there. It's pretty rare that I see 750 of Cipro used twice a day, so that's obviously probably going to be more serious and severe infections. Most common dosages are 250 and probably 500 is the most frequently used dose for treating an infection with oral Cipro. IV dosing, typically we're going to use 400 milligrams every 8 to 12 hours. I do want to mention that because of the pharmacokinetics of Cipro, the oral bioavailability is in the neighborhood of 70 to 80% for Cipro. And obviously the IV bioavailability is 100%. So we've got a little bit of a ratio going there of 4 to 1 4 to 5 in that neighborhood, where 4 milligrams of IV, you're approximately going to get the same dose out of 5 milligrams of oral. So in the real world, 400 milligrams of IV, I alluded to that being a common dose, is approximately equivalent to 500 milligram dosage form of the oral ciprofloxacin. Okay, so that's a nice little one to remember there, and that's all due to the pharmacokinetics and the bioavailability of this medication. Another really important thing with regards to dosage forms and kinetics is with dosing, this medication is cleared by the kidney primarily. So if you've got patients with poor renal function, you may see that dosing interval extended, or you may see the dose needing to be reduced. So pay attention to that. If you're not sure on that, look that up. Or if you know you got a patient with CKD, definitely pay attention to the fluoroquinolones in general, but ciprofloxacin specifically here as well. All right, let's get into adverse effects and some of the boxed warnings. So most common adverse effect, probably like most antibiotics, are nausea, stomach upset, diarrhea. But we can have some CNS adverse effects as well, some dizziness, some insomnia, confusion, headache potentially. Photosensitivity is another good one to remember for those outpatient patients who are taking oral Cipro, making sure that they're aware that they may be more susceptible to getting sunburn in those specific areas, obviously, where there's a high instance of sun, or the times of year where there's more sun out and available as well, and patients are more likely to get sunburn there. Pay attention to diabetic patients. We can have some variation in blood sugar potentially, maybe getting too low in some instances. So again, keep an eye on that. If you're using Cipro and we know we've got a patient with diabetes, maybe they're taking insulin, for example, may want to watch those blood sugars a little bit more closely. And keep in mind the infection itself and the stress on the body that can cause some fluctuation in blood sugars too. So oftentimes that's difficult to decipher what's causing the alterations in blood sugars. But again, maybe just pay a little bit more close attention to monitoring those blood sugars in those patients. And then those boxed warnings I wanted to talk about. So the really rare, unique one, definitely a good board exam question, is tendinitis and tendon rupture. Ciprofloxacin definitely, has that risk associated with it, and is, one of the rare medications that can have that risk. So risk factors for this, elderly patients, immunosuppressed, transplant patients, patients on corticosteroids. These are all potential risk factors that may increase that risk of spontaneous tendon rupture. A couple other things, peripheral neuropathy. So that, in rare cases, can be permanent as well, even after the medication is discontinued. And then there's been CNS effects reported as well, anything from delirium to psychosis to agitation to even seizures potentially. And really all these warnings have really reduced the use of this class of medication, and Cipro specifically here. So when many years ago, 10, 15 years ago, when I first started practicing, it definitely seemed like the quinolones were used a lot more frequently. And since these warnings came out with this medication class, as you can imagine, the use of ciprofloxacin and other quinolone antibiotics has reduced since that's happened. So definitely something to pay attention to there with those boxed warnings. One last one, exacerbation of myasthenia gravis as well. Adverse effects are on the rare side. QTC prolongation risk is a potential concern. Maybe a little less than some of the other quinolones, but definitely should be considered in patients at risk for that. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, NAPLEX, BCMTMS, or geriatrics, go check out meded101.com/store. We've got a growing list of resources there that will help you prepare and pass your exam. We've helped thousands of pharmacists and students already pass their exam, and we can absolutely help you too. So go check out all those links, meded101.com/store. In addition, if you're a nurse practitioner, nursing student, med student, pharmacy technician student, go check out meded101.com/store. We've got resources for all different types of clinical practice, good education on pharmacology and medication. So go support the sponsor. Go take advantage of that, meded101.com/store. All right, wrapping up with drug interactions. So first and foremost, oral ciprofloxacin. You've got to remember that this medication binds to a lot of supplements, okay? So your cations like iron, calcium, magnesium, zinc, aluminum, any type of supplement with those components or one of those components in it can potentially bind up oral ciprofloxacin in the gut and dramatically reduce absorption. We're talking potentially 50% or more in some situations. So, giving those medications, let's say a calcium supplement at the same time as Cipro, which again, that's a classic example because we often give calcium supplements twice a day, and then we give ciprofloxacin twice a day as well when treating an infection. So if we give those at the exact same time, we're essentially reducing the dose by probably in the neighborhood of half, sometimes maybe even more, depending upon other factors and what's going on. So again, gotta remember to look that up if you're writing a prescription, if you're dispensing it, if you're educating a patient about ciprofloxacin. Make sure that they're aware of some of these supplements and other things they may be on, and that we need to, at a minimum, separate timing. So let's say taking the Cipro 2 hours before you take your iron or your calcium. The other thing we can do, and I've seen it done in practice a handful of times as well, if we've got a 5-day course, 7-day course of Cipro, we can potentially just hold the iron or the calcium, and typically that's not going to be catastrophic for a patient. So that's kind of the other option too. If patients are having trouble with that time separation and remembering to take their other medications and those type of things. So a couple different options there, but we really want all that ciprofloxacin to be absorbed, or at least what we expect to be absorbed to actually be absorbed and try to treat the infection. So we know that it's treatment failure due to resistance or something else, rather than treatment failure due to inadequate concentrations because that drug was bound up. So really pay attention to that. Can't stress that enough. I've seen it probably hundreds of times in my career as a pharmacist. Next one I wanted to mention was CYP1A2. So ciprofloxacin inhibits the CYP enzyme 1A2. There are a few medications that can be affected by this. Probably not crazy common medications, but something to think about here. So tizanidine, skeletal muscle relaxant, clozapine, olanzapine, those are antipsychotics. Theophylline, can't say I've seen that medication used for quite some time now, but that's a very concentration-sensitive drug for respiratory type of conditions there. Even something like caffeine can have concentrations increased there as well. A couple other things. Warfarin So increased risk for bleeding, bruising, elevated INR. So pay attention to that. May want to do a little extra monitoring in somebody that we're giving Cipro. May want to check that INR a little bit sooner than their kind of regularly scheduled routine check. And then last but not least, obviously QTC prolongation risk. Antiarrhythmics, antipsychotics, macrolide antibiotics, lots of different medications can cause QTC prolongation. And Cipro could certainly have some additive effects on top of that. All right, well, that's going to wrap up the podcast for today. Hopefully you picked up a few practice pearls or things that come up on your board exam. If you did, do me a huge favor. Leave a rating, review on iTunes or wherever you're listening. I greatly appreciate that. Also, go subscribe, reallifepharmacology.com, and of course, support the sponsor, meded101.com/store. If you got questions, comments, feel free to reach out to me, mededucation101@gmail.com. Otherwise, you can connect with me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. With that, I'm going to sign off. Take care. Hope you have a great rest of your day.